I will introduce our esteemed visiting scholar today, Dr. Monique Pappadis. Uh, Dr. Monique Pappadis is a tenured associate professor in the Department of Population Health and Health Disparities at the University of Texas Medical Branch at Galveston. She's also an investigator and the director of dissemination and cultural humility at Tier Memorial Herman's Brain Injury Research Center in Houston, Texas. Her research aims to improve rehabilitation and care outcomes and decrease ethnic minority health disparities, particularly among persons with traumatic brain injury, TBI, or stroke, as well as improve care, transitions, and continuity of care following acute and post-acute care. Dr. Pappadis was named a Fellow of the American Congress of Rehabilitation Medicine for her professional service and nationally significant contributions to the medical rehabilitation field. She was also recognized by the National Institute on Aging for her commitments and contributions to enhancing diversity, equity, inclusion, and accessibility through mentorship of underrepresented student trainees. So, as you can tell from the topics, I'm very excited to have Dr. Pappadis here to speak with us. We know her well she's also involved in the traumatic brain injury model systems and has done a lot of work with them. And we are fortunate to be able to call her a collaborator. Today, she'll be speaking on elder justice and health equity in traumatic brain injury.
So thank you for the invitation, and I'm so excited to be able to speak today about these two topics. I've been working in the area of health disparities and traumatic brain injury for some time. And over the past just a few years, I started working more into looking at elder justice, specifically elder mistreatment. And so I'm kind of happy to kind of bridge the two worlds together in my current work. So just quick acknowledgments to all the funding that have supported the work that I will be sharing today. Also acknowledgments from organizations that I'm affiliated with as well, Pink Concussions and the Brain Injury Association of America. So just quickly overview, I know there's a lot of bullets on here, but first I'll just talk about, what is elder justice and health equity. I'll discuss how older adults, they're think of older adults as a health disparity population, TBI and health disparities in treatment outcomes, and also kind of what happens after leaving the hospital after a brain injury and associated outcomes, as well as the idea of access to rehabilitation, and that work there is where I'm working with two medical students who are interested in becoming PM&R physiatrists, PM&R physicians, and also one doctoral student who's more, kind of interested from the angle of policy. And then lastly, I'll talk about how some of the kind of preliminary work that we've been doing that kind of bridges or combines these two worlds of traumatic brain injury and protecting or evaluating what happens with regards to abuse among older adults. So elder justice, what we mean by that is just really kind of fostering social structures and creating policies that enable older adults to be able to remain engaged in their communities and societies as a whole. So really thinking about absence of abuse, absence of neglect, whether that be neglect by someone else or self-neglect, as well as exploitation, financial exploitation, fraud, and other forms. And so what I mean by health equity, I like to use this particular definition, just again, achieving when an individual and every person is able to have that opportunity to attain his or her, their full health potential, and no one is disadvantaged, right, from achieving this particular potential based off of their social position or any other socially determined circumstances. And so a lot of the work has been focused on health disparities and kind of these preventable differences related to disease, injury, violence, and opportunities to achieve optimal health by socially disadvantaged populations. And then when I am discussing about social determinants of health, I'm referring to, kind of these economic and social conditions in our environment, using the CDC and World Health kind of idea of social determinants and how they affect our health, right? How we function, any risks that are associated with these conditions, and associated outcomes. And when these are distributed unevenly, that's when these health disparities occur. And then thinking about how there's these systematic differences that occur, structural differences, structural disadvantages. That's where you have these health inequities among different groups. So I like to, anytime I talk about health disparities, I often go to this particular framework by the National Institute on Minority Health and Health Disparities. I'm sure all of you are familiar with this, but just thinking of, when I started, we were very interested kind of on the individual level of how different factors influence health of that individual, bringing in the caregiver and how the caregiver and how that diet may play a role in health and health outcomes after brain injury. But since over the maybe I guess 5 or 6, maybe a little longer than that, years, kind of focused more on kind of looking at health and health from this population standpoint, thinking about overall kind of the quality of care that nationally individuals with brain injury receive, as well as looking at how different policies influence that care and outcomes, and then also looking at are there specific things within one's environment, and how that plays a role in health and health outcomes. And so lastly, I'll just put this up as kind of a model. Again, I like to put up all these different models that kind of give an idea of kind of a framework to use to not only decide on what to research, as well as helping with the interpretation of our findings. So this is the most recent model developed by NASM, the National Academies of Science, Engineering, and Medicine. Just thinking about this entire overall perspective of how TBI can influence. After TBI, one has a TBI, there's different trajectories of what happens after that, and in particular when they engage with the healthcare system, and every system is different. And so as you can imagine, when you consider the health care system, as well as, thinking someone's social environment, physical, environment, and how all of that plays a role related to someone's health and outcomes over time after injury. So I think of started becoming really interested in older adults as a health disparities population, just because, as you'll see that they're more often, when I was seeing the patients that were coming in at an inpatient rehab, I noticed that the demographics started changing and they became, they were older and older. Before, I used to always wonder where are all the older adults? Where are they going? They were going to skilled nursing facilities, but now the kind of demographic at many inpatient rehab facilities and possibly at Moss Rehab is the same, that there are more older adults who are being admitted with traumatic brain injury in inpatient rehab facilities. So, we've focused on a lot of, racial and ethnic minorities. Girls and women's are often underrepresented in TBI research, as well as sexual and gender minorities. young children, the pediatric population, as well as older adults. And that's, again, that's the group that I have been focusing on more. But also, I think of it as this intersection, right? So I look at older adults, but I look at racial and ethnic, differences among older adults, socioeconomically disadvantaged, looking at, you know, if everyone has the same type of insurance and coverage, why do these disparities still exist? And then also underserved rural populations. So as I already mentioned, older adults are kind of surpassing adolescents and young adults with hospitalizations, with TBI related deaths. And so many of the reasons are, as you know, accidental falls, motor vehicle accidents, or being struck by an object. Some of the work that Raj Kumar and colleagues have done really help, kind of made me even more interested, because the one of the big challenges with providing care for older adults is how do you best manage all the different chronic conditions that they have in addition to the traumatic brain injury. And so I've been working with some geriatricians who are used to this, used to caring for individuals, multi-morbidity, to help, how do you operate in this kind of new framework of, how there's all these other conditions that could be playing a role in outcomes. So I'll just briefly mention that, we're really interested in kind of this long-term management of traumatic brain injury, that just really aligns nicely with the older Institute of Medicine's recommendations related to managing long-term, brain injury long-term, especially with regards to self-management, being able for individuals to access not only medical care to treat these comorbidities and complications, but also being able to access rehabilitation care to improve functional abilities. And then, as you know from the Galveston Brain Injury Conference, there were many recommendations that were put forth relevant to kind of my work is, what how to best, understand when individuals are able to access primary care as well as specialty care after brain injury, whether or not they have a relationship with their primary care provider, and looking at kind of timing of when that interaction occurs and how that impacts outcomes. And again, just thinking about, at least on the individual level, how can we um, help with getting individuals with traumatic brain injury as well as their caregivers on board to help better manage any conditions that they have following brain injury to help improve health outcomes. So I'm just showing this chronic care model is what, we've kind of been using as a guide to look at outcomes related to care and, accessing different types of services within a healthcare system, the role of the patient, as well as, the integrated multidisciplinary team, and how that interaction between the patient and the provider, throw in caregiver as well, and how all of that interacts to improve outcomes after injury. So a lot of the work that we've done has focused on kind of the health disparities and, treatment and outcomes. And so, as you know, there's so many different points along that care continuum. And a lot of the work, there's been studies that, have found that disparities exist, with just, access to, say, a level 1 trauma center, or the type of surgical intervention that has occurred post injury. A lot of the work and disparities have focused more on that transition from, okay, when someone's in acute care and their ability to access rehabilitation services, what we really don't know, the areas where there's still more work to, really understand is what happens after that point. Access to outpatient rehabilitation services in the community. Also, what happens with individuals, many individuals having to go to a nursing home after injury, and even young adults, right? There's been an increase in the number of young adults who are having to stay and live in a nursing home than before. And then thinking about what happens, during those last years of life after injury, what type of optimal care that they're receiving during that time. So we know that there's a lot of disparities, right, with access to rehabilitation, especially from, looking at racial and ethnic minorities. There's a lot of research that has been conducted, really, and some of my work have kind of just, uh, you know, have found similar results that Hispanics or Latinos are, less likely to receive rehabilitation services, if they're undocumented or Spanish speaking, again, limited access to rehabilitation. And the same for non-Hispanic Blacks with the level of, being discharged to facilities that are considered, less as intensive than say like an inpatient rehab facility. And even when you look at, you know, whether or not individuals have insurance, so throw in insurance because oftentimes one says, oh, okay, well, it's really insurance that is the driver. Oftentimes, even if you have everyone with the same type of insurance, there's still these disparities that exist. And same when you look at older adults. We find the same, very similar results with, older Hispanics and non-Hispanic Blacks are, twice as likely to be discharged home than to some form of rehabilitation service or facility. And so that's just consistently found, even if you, again, have the same type of Medicare coverage, individuals are still less likely to receive, that same or similar level of intensive rehabilitation as non-Hispanic whites, for example. Same with returning to home, similar, we find similar results with older adults. Again, they're more likely to be readmitted than younger adults. They're, often transferred to inpatient rehab facilities or skilled nursing facilities, being institutionalized in a long-term nursing home facility. These are the I mean, it's limited research out there, but this is kind of the pattern of care that's occurring. So, what we know is that there really aren't any true clinical guidelines that help address this aspect of kind of this long-term care needs of older adults with TBI. This is, work that's ongoing. We really don't know about the different types of patterns of care at, along that continuum of acute and as well as post-acute care. And then a lot of discussion has been occurring about, the role of primary care and whether or not individuals are having access to primary care, and whether or not that, again, if there's this partnership between rehabilitation professionals and primary care, will that help improve outcomes? And we really don't know that much about elder mistreatment, the kind of this intersection between elder mistreatment and TBI. I often say, a lot of older adults are having falls, but how do we know that these falls aren't as a result of being pushed or other type of forms of injury to one's head, facial fractures? How do we know that they're not as a result of physical abuse? So, with the work that we're currently doing, we're kind of looking at older adults with TBI and really kind of answering some of these questions where there's just limited research available. Again, we know that the older adults are at greater risk of sustaining a TBI with these long-term outcomes. They're, millions are seeking care, where, about a quarter of those individuals are older adults. And we know that, again, especially for individuals 75 and older, there's just been this increase in hospitalizations among older adults. So my framework for the research has really been focused on this kind of model of looking at all the different, disease related or clinical related factors, patient level factors, and kind of where they are, geographic location, and how that impacts, access or the care that they receive, not only TBI related, but also specialists, cardiology or primary care, and then also what type of therapy individuals receive, whether that be rehabilitation, that could be OTPT speech, as well as behavioral health. And then how does all of this play a role, if someone has a primary care provider or someone, a usual provider, does that help with improving outcomes after brain injury? So looking at a variety of outcomes, and I'll just be focusing mainly on the outcomes related to readmission and being able to return home after injury. So what we found, again, I'll have to emphasize that this is this particular data that I'm presenting right now is related to Texas, 100% Texas data. Some of the data I'll present in a minute is related to 20% national data using Medicare claims and assessment files. So what we know is that, this is kind of the path of these individuals where, little under half of those individuals are discharged directly home after a brain injury. But then as you could see from, the figure, that there's a lot of variation, right? Like IRF, by the 2-week period, there's a big drop. Skilled nursing facilities, many individuals are being transferred from acute directly to a skilled nursing facility. And as time goes on, that decreases. And then as time goes on, more individuals are being institutionalized in a long-term nursing home. We looked at kind of what factors kind of play a role in, being able to, at some point go home and be able to stay in your home. Currently, the, quality metric of, successful community discharge is 31 days, but we kind of expanded that. We just wanted to see in a 3-month time period after discharge, is someone likely to be able to return home? And so we found that females, Hispanics, individuals that identify as other race or ethnicity, and those who previously had a primary care provider, they were more likely to be able to be home and return home after injury. And then when we looked at those who are often hospitalized again after their brain and, after being discharged home, that often it's, non-Hispanic blacks are, who are discharged to a skilled nursing facility or to inpatient rehab facility were, had the highest risk of being readmitted after discharge home. Similar if, someone having a prior primary care provider pre-injury, like a usual provider, as well as Medicaid, Medicare, Medicaid dual eligible individuals, as well as those who had a history or previous history of having a traumatic brain injury, were likely to be readmitted later on. So I highlight this fact of the primary care provider because that was like really interesting, and we decided let's kind of explore this a little further. We looked at primary care utilization, and really wanted to know, are there any disparities related to just access to a primary care provider after having a traumatic brain injury, kind of like the timing of that. And so we looked at, outpatient visits. We looked at, who is the primary care. We only focused on, um, you know, general medicine, family medicine, internal, geriatrics. We also included nurse practitioners because many older adults may, just see a nurse practitioner, as well as physician assistants. So that's who we were looking at. And then we looked at if anyone had kind of that established primary care before their brain injury. So we just identified all their visits and who's the provider that they saw, saw the most. And that was their kind of quote unquote established primary care provider. So this is just a snapshot of like what we originally found. As you can see on the left, many individuals do not have a primary care provider. But then a lot of older adults do, and they see them quite often with, up to a little under 7% would have, before their brain injury was seeing their primary care provider more than 10 times within a year. So you would imagine that these, our guess is these are the individuals who may have more comorbidities and more illnesses that require more frequent visits with the primary care provider. We kind of looked at over time whether or not there's these differences between those who had a primary care established provider and those that didn't, and just looking at, when they um, uh, you know the time from discharge, and followed them, roughly 3 months after that point. And so as you could see, individuals that had a kind of established primary care provider, they're more likely, right, to or earlier on begin to start seeing their primary care provider after they're discharged home. So as I mentioned, we were really interested, are there these differences? Are differences exist in just having that access, that time to seeing a primary care provider? And of course we did. We found, age differences, sex differences with race and ethnicity, as well as, having an established person pre injury, and whether or not they had a TBI before. Um, all these individuals at the top, as you could see, they were more likely, to see a primary care provider once they're discharged home, whereas those who weren't, we were shocked to see that, those aged 85 and older were not. My guess is that, even though we kind of accounted for if they had hospitalizations later on afterwards, and account, which one occurs first. We were surprised to see that group. We thought that, the more older individuals would probably have more visits and probably would see them, but there seemed to be like a delay of when those 85 and older actually saw a provider. Same with if you compare Black race, individuals with identified as Black versus those who identified as white. We saw a difference there with Blacks less likely to have that primary care visit. And then, as you can see, another thing that stuck out to us is related to, that transition. So, those that were discharged directly home were less likely. Those that transitioned from acute to SNF or acute to nursing home also was less likely. Those that had more comorbidities, which was interesting, as well as longer length of stay. when we also looked at, kind of the rate of seeing that established person. So previously it was like, okay, any primary care provider. Now it's kind of looking at, let's see those that the factors that are associated with seeing that usual person that you saw pre-injury. And so some of the findings are very, very similar with regards to, increased rate with this 75 to 79-year-old group, Hispanic ethnicity. Again, makes sense. If you had a usual care provider before, you're more likely to see that same person again. And then interesting, those that transferred from an acute hospital to inpatient rehab were likely to have that primary care visit afterwards. And again, with the decreased rate, those findings are very similar to what I found earlier with any visit. So we kind of was trying to figure out like what's going on here with the primary care provider and outcomes. So we looked at, whether or not someone had that established primary care provider. Does that play a role in addition to like where they were discharged to? Does that play a role in outcomes? And we did find that there was difference. So those that, had a established primary care provider discharged home, they were less likely to be admitted, or sorry, have a emergency room visit, as well as be readmitted. And then those that went to an IRF, for very interesting, they had a greater likelihood of, having a emergency room visit following their IRF stay. So now just go into looking at, we move from that to, again, working with me working with these medical students to look at, okay, are there disparities in access to rehabilitation among this older adult population that, have Medicare coverage? And so these are the two future physiatrists, Caitlin and Chinadu. So the research really is focusing on, really focused on disparities in access to rehabilitation. We focused only on home health care and outpatient care rehabilitation because that's areas where just we really don't know much about. And then we're also planning to look at various social determinants of health and how that impact utilization of rehabilitation services um, after TBI. There's a training component where we're creating inclusive mentoring modules as well as a faculty training workshops embedded into this project. This is a little hard to follow. Essentially, I would just say that we followed people up to 1 year after they were discharged. Just tracking like literally daily where people were. And then at that time point, we saw that many individuals who were finally able to go home, there were, uh, roughly, you know, many of them were able to receive rehabilitation after, being discharged to the community, but many others were not. They either had to be readmitted to a skilled nursing facility, a hospital, be, admitted into a nursing home or hospice care. We looked at kind of just what type of care that they received in the outpatient. As you can imagine, many individuals received physical therapy, occupational therapy. The ones that didn't wasn't frequently used was speech language pathology, as well any type of social psychological services provided by either a clinical social worker or a psychologist. So we looked at, kind of what is these factors that play a role in, accessing rehabilitation in that kind of either home health or outpatient rehab setting. And so we found, very similar. We found age differences. We found racial differences with, older adults, uh, more likely to have well, all of them are older adults, but the older cohort um, were more likely to have a rehab visit, one of these outpatients or home health visits. And then we saw that racial differences with Blacks and Hispanics, or those that were identified, well, not Blacks and Hispanics, have less likelihood of having their rehabilitation visit either in an outpatient or home health setting. We saw differences with those Medicare dual eligible individuals being less likely, um, prior TBI history more likely. And then we saw significant differences, right? Like depending on where people were discharged, where, say post acute care individuals, they were, more likely to have another type of rehabilitation visit post discharge in, an outpatient setting. And similar, we found with related to comorbidities and, more severe injuries. So with regards to elder justice and TBI, I was again really thinking about, we've been focusing on elder mistreatment and TBI, and then the question is, how often, individuals that are have physical abuse, do they have a traumatic brain injury? Are they more likely to sustain a traumatic brain injury later on? So just to let you know, elder abuse and elder mistreatment, the field has really changed over the past 10 years to kind of get away from this idea of focusing on abuse and mistreatment as far as language, to really thinking about justice and how do we protect older adults. But older adults are often, who are abused, are more likely to die than those who do not sustain any type of abuse. And, cognitive decline is often a risk factor for elder abuse, as especially regards to financial exploitation. We know that roughly 1 in 10, and obviously we think that these are underreported, but among those that are reported, the estimates is roughly 1 in 10 older adults sustain some form of abuse or maltreatment. And those who are abused are more likely to be placed in a nursing home than those who did not sustain in a form of abuse. And elder abuse is, as I mentioned, is really underreported, with really 1 in every 23 cases. This is estimated, actually moves on and gets reported to Adult Protective Services. So this is kind of the framework that we've been operating on, with, really trying to identify individuals without any signs or symptoms of abuse, to be able to screen so that we can be able to identify individuals who have been exposed to abuse or at risk for abuse, develop some form of intervention to help address that and reduce that risk for abuse, physical harm, death, and ultimately improve the idea of improving quality of life by reducing these associated harms. So oftentimes, we look at elder mistreatment, intimate partner violence, or domestic violence, but really this interaction, this, piece between that's related, is looking at abuse that occurs in late life. So different forms of abuse by someone that's known, in that occurs as an older adult. Excuse me. So, what is abuse in late life? Again, we know intimate partner violence, domestic violence. It occurs often when individuals engage in new relationships, new partnerships, new providers, for example. Um, or it could occur just, it just happens later on, or they had a prior history of experiencing intimate partner violence or domestic violence. And then, excuse me, the former victim, may often, become a perpetrator, because they've experienced abuse so much prior, and so now they are, um, all that pent up frustration. Often, what's expressed is that they end up becoming the perpetrator. So what we don't know that much about, like, the true prevalence of this occurring. Some suggest that intimate partner violence decreases with age, but we really don't know. We don't know. We know that it can occur across the lifespan. Oftentimes assessments and services are geared towards the younger survivors, and not as much focus has been on older adult survivors. And so there's a lot of different considerations that have to be taken into account, such as individuals age, their health declines, and if they're living with disability. Some of the work that my colleague Dr. Wood has done has, really explored, these what are the kind of concerns that older adults may have. Obviously, financial abuse, with debt, housing insecurity, and economic instability that kind of really puts them at risk for experiencing, continued abuse or assault, for example. And then COVID kind of just negatively impacting individuals, right, with decreased social support and often being isolated. We saw that, older adults, may they can access they have these different programs that are available to help with older adults, but oftentimes these services are, often received when there are referrals made from either, law enforcement, if hospitals, courts, or APS. So we were really interested in this hospital piece, and, exploring what really happens when individuals have elder mistreatment, who, have to be hospitalized. And then we also, some lessons learned from some recent work. We know that there's some accessibility issues. There's a need for advocacy and support for older adults, and there's a need for, making sure that that services are culturally appropriate for them as well. This has been the framework of the respect framework that has been used to really understand and providing care and services to older adults, survivors, being responsive. The victim defines their advocacy, really informed by the older adult, providing these services, and, providing safety planning, outreach, making sure policies are appropriate for older adults, again, equity, and making sure access to those services, and providing, collaboration with a lot of multidisciplinary teams, and providing training and awareness to all to be able to respect and provide, appropriate care to this population. So what we did was we looked at 100% U.S. Medicare fee-for-service beneficiaries, and we only focused on those that were 66 and older. We basically, I know there's a lot of words on here, but we looked at various forms of abuse, from physical, psychological, sexual, psychosocial circumstances. We didn't include those with HMO. We only focused those with the Part A and Part B. And then and then those who we followed, individuals who were hospitalized from 2015 through 2018. Sorry, my dog. And looked at kind of them who were diagnosed with elder mistreatment, and looked at different associated outcomes with that, such as readmission and 1 year mortality. And we looked at different types of elder mistreatment, how that may play a role, the facility where they received care, um, and whether or not it was they were primarily admitted or secondarily admitted for elder mistreatment. The only real hypothesis we had, we thought that those who were primarily admitted for elder mistreatment would have, the greater risk for mortality and readmission after discharge. But what we found was that, obviously, various forms of abuse, associated, for example, neglect was a big one that, individuals in comparison, those that had other forms of abuse were more likely to experience death after hospitalization or a discharge after being discharged from the hospital. Um, Opposite of our hypothesis, the primary abuse is actually those who were primarily admitted for other reasons had the highest risk, and not those with primary abuse. We're just thinking that they may have had a lot of uh, injuries or things that had occurred that took priority, and so that was kind of their main reason for being admitted into the hospital. As well, we found that those that were at a sniff had poor outcomes as well. Similar, when we looked at kind of readmission, we found kind of very similar results. Again, neglect is, poor outcomes related to those that experience neglect. Similar results with regards to primary abuse. And again, those who received care in a skilled nursing facility, they had the worst outcomes compared to those that were admitted, that only received care in an acute hospital. So then we thought, okay, let's look at, the role of traumatic brain injury and how that play a role. So we looked at, this uh, it, older adults who were hospitalized for an elder mistreatment during this brief time period of 2015 to 2018. And then we looked at, whether or not they had a TBI previously, whether or not they had a TBI again post injury and or post hospitalization. We found that only a small percentage, but still significant, had a previous TBI hospitalization before they were even admitted for elder mistreatment. We also saw that older adults were more likely to have a TBI after, as well, after their hospitalization, roughly about 4%. And then of those that had a TBI again, they were more likely females than males, Hispanic or other race. Um, Medicare, and I just want to preface that the naming of the categorization related to race and ethnicity by CMS, they kind of combine. So it's Hispanic race, Black, white, or other, and the other could just mean any other particular race that of an individual who does not identify as Black or Hispanic or white or Asian. Um, the Medicare individuals with Medicare versus those with who are dual eligible with Medicare and Medicaid were likely to have a TBI, which is interesting. As one would expect, that those for physical and sexual abuse, they were more likely to have a TBI after being discharged from the hospital. And again, as we all know, individuals that have a pre-history of TBI, the recurrent of, there's a high likelihood of sustaining another TBI after the index TBI. And so what we did, we wanted to see if whether or not having a TBI had any associated, relationship with any of the outcomes after hospitalization, such as readmission and mortality. We did not see that. We only saw that, as you can imagine, those who who were hospitalized for form of physical abuse, sexual abuse, or neglect, those with the secondary diagnosis of elder mistreatment, or those who were admitted to a skilled nursing facility. Those individuals were more likely to be readmitted, and more likely to pass away following hospitalization. So to combine this, kind of what the new work that, hopefully I'll have so much more to share at another time, is, we're really trying to improve the screening for elder mistreatment. And so, because it's underreported, not detected, and especially we think that in these primary care settings, these are kind of the ideal places, one of many ideal places to screen for individuals, screen patients for elder mistreatment. We really believe in universal education, so just really following the model of that everyone should be screened regardless of their suspected abuse or not, and then have a system in place that, you do the universal screening, you provide some form of brief intervention. If there's, elevated risk, then refer individuals for treatment, and then have this phase of follow-up. So what we're doing is basically following that same model that has been done, with screening for alcohol and substance abuse, for screening, for uh, uh, psychiatric conditions, for example, that have used the SBIRT model. We're basically taking that same model, but applying it to screening for elder mistreatment. And so our hope is, we'll be assessing all individuals who have some form of cognitive impairment, from mild to the most severe, such as someone with later stage Alzheimer's disease, for example, and screening both not only them but also their caregivers. Um, and then again, as I mentioned, providing this brief education to help hopefully improve screening in these settings, as well as provide better supports to help support caregivers and family, to provide support of individuals as their cognitive status changes over time, and of course, assessing for prior history of traumatic brain injury, and following up individuals afterwards for if there's any new or recurrent traumatic brain injury after being seen in these settings. So, in conclusion of all the work that we've been doing, we see that older adults with TBI have, these varying trajectories of care after their injury. And despite being able to return to their community at some point after their injury, we still find these differences based off of sex, race, and ethnicity with their likelihood to be able to return back to their community. And then we also, again, we found disparities that exist, in these post-injury outcomes related to readmission and mortality, with, Black race, where someone is in post-acute care, having the role of a primary care provider, and their Medicaid and Medicare status, and again, prior history of TBI, were associated with an increased risk of readmission. We also saw that, again, disparities exist with regards to access to the primary care after TBI. And we also identified that, patients with a prior history of TBI were more likely to sustain another TBI among that cohort of individuals who were hospitalized for elder mistreatment. So our next kind of steps, other than the project, we're really interested in from this aspect of identifying, um, TBI, the intersection of TBI and late life abuse among diverse older adults to see, what's the actual prevalence of this occurring, them co-occurring, and the associated outcomes of experiencing abuse as well as having a traumatic brain injury. So just I'll give acknowledgments to some of the team members as you see here. This is the team related to the traumatic brain injury research and looking at disparities in care. And then this is our elder mistreatment team, that obviously me and Dr. Wood here are very interested in traumatic brain injury piece. So all the work that we're doing, we're always kind of exploring how TBI and elder mistreatment, as TBI may be under recognized among the elder mistreatment individuals that experience elder mistreatment. So I will go ahead and stop there. Thank you for this opportunity.
We'll take questions now.
Hi, Monique. Thanks for the excellent talk. Really fascinating stuff and a lot of great important work. I'm thinking about the putting the piece together of discharge location and care and also elder mistreatment. And I know that you also have done a lot of work on caregivers, but seeing patients as they're discharged from inpatient rehab, there's often like the issue of, we want to get them home. That's a good outcome, but is there any caregiver in the home? Is there a supportive caregiver in the home? Is there potentially an abusive caregiver in the home? So it's like you can imagine that going home, if you have a supportive caregiver, can be the best possible scenario. But for a lot of our patients who don't have that, SNFs are usually seen as not the best place. But it seems like it's a kind of a complicated interaction between like what is the quality of the home environment and is there a supportive caregiver available? Because home could be like a really bad place to discharge for patients who are in these abusive situations.
Exactly. Yeah, I completely agree. We look at discharge right to community as a success. But just to that point, but we don't know, much as you say, how that environment that the individual is going, what environment the individual is going to may impact, outcomes and how can we and so that's some of the work that we're trying to do. How do we best support caregivers in that process, definitely to help reduce potential risk of being a perpetrator of elder mistreatment. But yeah, it's extremely complicated, and it's really hard to look at everything. Kind of I showed you kind of things kind of in isolation, but just taking a step and looking at the big picture, there's just so many unanswered pieces. And but yeah, I completely agree. Sometimes it's better that an individual may have to be, at a skilled nursing facility or in a nursing home versus in a home that is not supportive. Dr. White, I think.
Yeah, Monique, thanks for the great talk. I think you made a very persuasive case about the disparities and certainly the ethnic and racial disparities within older folks. I wanted to probe a little bit the notion of older folks as a disparity population themselves, specifically for access to rehab care, because obviously there are negative stereotypes about older people, but there are also actual developmental changes in older people that I can personally testify to. So, when I saw that older age predicted outpatient therapy, or no, I guess it was home therapy, I thought, well, Yeah, I thought, well, maybe that's because those are the folks who are frail and don't have highly active, like I want to return to playing sports. I just want to be able to, walk around the living room. So,
Hmm. Hmm.
so, um, and similarly, it's possible that some of the referrals are driven by person-centered care, where the person says what stage of life they're at and what their goals are, and it doesn't seem like an inpatient rehab makes sense. So how do we tease apart the legitimate changes in goals for older people that might occur from the sort of discriminatory stereotypes that shut out possible goals?
Yeah, so some of the work, or obviously the work that's not presented will kind of get their point of view, right? Like from the qualitative piece to get their point of view of what's important. Their process on thinking like what's the appropriate, um, uh, the decisions that they make in collaboration maybe with the healthcare team on deciding what is the most appropriate care transition following acute care. And then as what you mentioned about, um, yeah, for the results, again, um, again, it's only in this small piece, but you made an excellent point. The fact that individuals who were older, that receive this outpatient and home health care, as you know, right, to be eligible for home health care is usually homebound, more frail individuals. And I think that is probably what is driving these results. Um, you give a excellent point that I think what I will probably do, which we have not done, is separate out these two groups, right? Like we combined them just to say, access to rehabilitation in that kind of home, like either home or in their community, but really those are kind of two separate groups. Those that receive home health versus those who are not homebound and able to receive outpatient care. And then your point about the older adults as a health disparity population, that's coming from the point of that older, just from and I get what you're saying, but from older adults, when you compare them to younger adults with injury, traumatic brain injury, their outcomes are just significantly different. Um, uh, and so my point of kind of making that kind of bold statement is really, I just feel that we need to focus on older adults and you know really think about how can we make do we need to modify the type of care that is being received after traumatic brain injury for older adults. Are there supports, better supports that could help improve those outcomes after injury? Um, so it was more from that point of just, the fact that being an older adult and sustaining a traumatic brain injury, um, death it frequently occurs, as well as greater disability following injury. I hope I addressed your comment.
Yeah, thanks.
Thank you.
Nice thing.
Yeah, go ahead.
Just a quick,
No, go ahead.
quick question about very, very interesting talk and it touches the heartstrings, I think, for all of us to think about this kind of thing. We're not so familiar with it happening, but it's so important. The question I had is about this, the outcomes relating to abuse of the older patients, and how do you actually capture something like neglect, especially when it might happen more. It might be more prevalent in environments that are harder to capture that it's actually happening, and the people in question, the patient and the caregiver, are maybe not reliable sources of that information. So it's like, we know it's important, we know it's happening, we know the environment that although it's interesting, your case that you showed, the picture you had was actually looked like a skilled nursing facility, so it looked like a professional that was maybe abusing, but I'm imagining that it's hard, where there's a third party, maybe you can capture it more easily. But I'm just imagining, how do you capture something like neglect in the home with the two sources that you might get that information from are maybe not reliable?
Can I add that, because I had a similar question, but mine, I had a question related to that from the cultural angle too. So how do you define that, especially when you're thinking of, Latinx families are very different, right? And how they define neglect and abuse. And so how do you operationalize that? Is there sort of measurement and variance, across the population? So yeah, how do you capture it in general, but how do you also capture it in diverse groups?
Yeah, so both of you mentioned some great points. So the work that we're, like in the moment doing right now is answering that question of getting perspective, the cultural piece, right? We know from some of the previous work, that there is these different perceptions of what's considered elder mistreatment and various forms of elder mistreatment, including, what's considered neglect. Because some cultures of whether or not an individual is like, to be able to, oh, this is their home, or this is where they live, it's okay, like I don't have to always be there be there with them, and that's kind of one of the comments that is often shared with some of the social workers, where they kind of leave individuals in the home that really need support and supervision. And then with regards to identifying, so in this particular study, were the results that I shared, it was neglect that was identified, through medical diagnosis of neglect. When we looked at individuals that were diagnosed with experiencing neglect, right, they were kind of off the charts in comparison to other forms of abuse, with like malnutrition. Their levels were all over the place. I mean, they just looked completely different. That's why some of the work, like we're looking at kind of everyone, all various forms, but some other investigators that are kind of working in this area space, they're only focusing on neglect because it's so complicated. To how do you best assess, like in the community, for neglect, both neglect by others as well as self-neglect, which people don't think about, but that it occurs just as frequent as neglect by others. So I hope I addressed both of your questions.
Any other questions?
I guess just one last thing. I just wanted to, it's just interesting. I was only really aware of the vulnerability of elders when I saw, like, my mom had to take over my grandmother's finances, and she's giving half of her money away to a bunch of different charities, and then my mom gets all these calls. People are trying to get her to give her social security and information to her computer, and they target elders, right? They have their information from the internet, and just how much, like, so is the research moving towards like education, just, I guess, vulnerable people, and then caregivers that, that I just only realized just through this experience, with my family, but that's something I should have been on the lookout for. And so I don't know, just raising awareness about vulnerability.
Yeah, that is definitely what's occurring is how what's a way to one identify specific uh, you know attempts of fraud or exploitation of older adults, like as you mentioned, through calls, through mailing, that seems legitimate. Um, and so some research has been thinking of ways how to best do that, either through like notification system, again, thinking of other kind of public awareness campaigns about the different forms, like what's considered um, um, exploitation, how to prevent and have safeguards in place, right, to prevent to not make you as vulnerable to forms of exploitation. Um, like having, like in our case, right, some of the ideas that we want to, how do we appropriately assess for um, potential risk of exploitation by someone in the family, like identifying like who all has access to your accounts or access to your home where you could keep you keep your finances, your cards, your bank statements, information. Do you have more than one person that could be able to assess, like if someone withdraws money, is there a third party to do that? Those are what we did that with my grandmother when her cognition was declining due to Alzheimer's, and we everyone had that particular role, and there was always someone who would watch uh, the finances in various points to make sure that grandma was protected. So so again, there's kind of this emerging body of literature that's trying to figure out the best way to raise awareness and help protect older adults so that none of this occurs.
Um, one of the things that you discussed in your talk was, and that had a great impact on outcomes, was established PCP, right? And I was wondering if between those two samples of the two samples, one where there was an established PCP and the other one where there wasn't, what were the differences in the health systems that they had access to, or insurance that they had access to? Was that the primary driver, or was it something else, like psychosocial aspects, or so what was leading to that disparity?
So meaning the differences, so everyone in that particular group, so everyone had at least Medicare, right, continuous coverage, but we did have the two types, right, like those that are Medicare and those with Medicare and Medicaid, and where we did see differences between those groups. But as far as um, the kind of key driver, the only thing that we saw that was had the largest effect was whether or not someone had a pre-established, when you're looking at the outcome related to just accessing a primary care provider following discharge, those that have that kind of established provider pre-injury was associated with, again, having that continued relationship and quicker access to a primary care provider. We still have to tease out, kind of more about, the role of primary care and how it plays, again, touching on access, um, you know, and looking at particular, for example, in their area, the location of where individuals are that may also play a role in access to not only to primary care but also to rehabilitation, um, access to providers. Because some of the work that one of my colleagues has done, he's really interested in that piece of it, of looking at where rehab practices are located, the distance from individuals, as well as like what type of coverage that they have, how that plays a role in access to rehabilitation services, and kind of trying to tease out some of these known disparities that exist. So
Cool.
yeah.
Thank you.
And this might be relevant to Shailis's question too, but I mean, I think that there's an overall shortage of primary care docs, and there's a particular shortage in ones who want to take the oldest old as new patients. So some of the people who are old and have a pre-established relationship, pre-establish that relationship before they were
exactly,
old.
Exactly.
But it's not that
exactly.
easy if you're already retirement age to find a new primary care doc.
Thank you.
I completely agree. Thank you. Thank you both.
I think Roberta has her hand up.
Hi, Roberta.
Hi, thank you so much for your talk. A lot of really important information. I was thinking too in terms of, I don't know if there's any way to tease it out, but that issue of existence with in an established relationship with a primary care doctor, can that be a proxy for just trust in the medical establishment across different healthcare populations?
Mm-hmm, mm-hmm.
And is there any look at that?
Yeah, so I quantitatively, like, we can't look at that, but the work that we're doing, where we're actually interviewing caregivers, persons with injury, as well as providers, hopefully we'll be able to tease some of that, or get something into it. But yeah, trust is one of the big ones related to identifying a primary care provider, maintaining that relationship with that individual. So I'm sure that may be playing a role in it as well.
And even like willingness to engage in outpatient rehab or engage in home care.
True. I agree.
I want to thank you, Dr. Pappadis, for joining us. It was a pleasure to host you here. Perhaps we'll hopefully see you in person sometime as well.
Thank you. Thank you for the opportunity. Great questions.
Thank you.